All right, now we're good to go.
Hey, so I have a question for you since I can't talk a lot. One of the things I ran into over the holidays was a family member who talked about getting really a lot of vaginal itching as she's gotten older.
Yeah.
And she's talked about how it's been treated for yeast, it's not there, BV not there, and her doctor thinks that she has one of the lichen family diseases. So I was curious if you wanted to share anything about number one, do you see this more often in the perimenopausal and menopausal years? And then number two, what people can do symptomatically, especially if they're not necessarily wanting to do things like steroids. What would you recommend?
Yeah. So just to start off, I'm Dr. Becky Lynn. I'm a gynecologist and I specialize in menopause and perimenopause. And this is not an uncommon scenario, especially as women get older. They get into the menopause, they develop some vaginal dryness. And a couple things that I want to point out is just having your estrogen levels be low due to menopause can cause itching and dryness. And a lot of times women call their office and they're like, I'm having vaginal itching, and they automatically get prescribed a diflucan or fluconazole for yeast. But what I want everyone to remember is not all vaginal itching is yeast. So if it's not getting better with diflucan, you have to think, what else could it be? And a lot of times it's just the menopausal vagina and lack of estrogen and what we call genitourinary syndrome of menopause. But the other thing on the differential for vaginal itching, especially in a post-menopausal woman, is something like lichen sclerosis. And this is an autoimmune disorder where women develop usually white patches in the vulva, and they can be really, really itchy. So that's another problem with call your doctor, I'm having vaginal itching, get a diflucan, because nobody looked. And lichen sclerosis is something that's really important to make that diagnosis because it's treatable and you don't treat it with the fluconazole or diflucan. Typically, you treat it with steroids, but it has a small risk of developing into a cancer, into squamous cell carcinoma. So it's really actually important that someone do an exam and look and make sure it's not lichen sclerosis. And the other thing about lichen sclerosis is if it gets bad enough, it can change the architecture of the vagina. So it can cause adhesions over the clitoris, and then someone might come in and say, I can't orgasm anymore. And then you do an exam, you look at the clitoris, and you can see that sort of the labia minora have sort of fused over the clitoris. And so that can really affect your orgasm. Other things you might see is the labia minora or the small lips get resorbed. So people with lichen sclerosis just don't have as much labia minora as other people, although they do shrink in menopause. But labia minora are sexual organs. So lichen sclerosis can definitely affect your sexuality. The treatment is usually steroid cream or an ointment, not a cream. And that really helps with that itching, irritation. The other thing people get with lichen sclerosis is fissures. They get little tears, and those can be really painful. So there's really not a sort of natural remedy to make it go away. But because it's an autoimmune thing, it's just, your body mounting an immune reaction against that skin of the vulva. We do use topical steroids. And the good news is they don't have the same negative side effects as like swallowing steroids or using them orally.
When do
Very
you
helpful.
suggest, like, yeah, when do they see you or their gynecologist, and when do you refer to derm, or is this something that derm also sees and treats?
Yeah, I think derm sees and treats, but I feel like it usually falls in the court of a gynecologist. So the times where I will refer out, and usually I refer to like a vulvar specialist,
Mhm.
are if everything I'm doing is not working. Which sometimes happens. Sometimes people can get it really bad. So like I can think of one patient who I had recently, um, who had bad lichen sclerosis. We tried different topical steroids and it just was not enough. And there are some centers that will do like injections of steroids. And I started to look into it myself, but I'm like, I don't do this often enough. I'm gonna refer out. And I know there are some centers that have looked at using laser to get rid of lichen sclerosis lesions, but there's not a whole bunch of data to support that, but there are some small studies looking at it where it might work. But if it's something that like I can't make somebody feel better, then it's time to refer out so they can get the help they need.
I've had a couple folks that have complained of it, and in some cases they've seen their gyne, and in a couple of cases, yeah, they saw somebody that specialized in vulvar derm. But my understanding is that that is almost like a smaller niche than even like reproductive psych. So
It is. It's a very small niche. There are some really good vulvar specialists throughout the country, and I have had people travel far to see vulvar specialists. Um, yeah, and I think that's a good idea. We're lucky we can travel and, get what we need. Yeah, because like I don't do laser for lichen sclerosis.
It looks like we have a question, 50 for 1 year into menopause, hot flashes for the past few years, then a break. Now they're back. Is it a myth that there could be a sign of cardiac risk or stroke? So I'll weigh in on this, and then I'll pass it off to you, Becky. So my background's internal medicine, obesity medicine, and this is something that we do quite a bit with of trying to risk modify. And I can tell you that yes, they're 100% a risk factor identifier. So it doesn't mean you're guaranteed to have a stroke. You're not guaranteed to have a heart attack just because you have hot flashes. But if you have those things, it's something that I worry about. Just like if you had diabetes or had high blood pressure or high cholesterol, I'm going to worry about whether you have a risk for having a stroke. There is really good evidence, and Dr. Lynn, you may want to weigh in on this as well, that using hormones within 10 years of menopause onset, when you have those severe vasomotor symptoms or hot flashes, can decrease your risk versus letting you just suffer. Because if you just let these be untreated, what a hot flash fundamentally is a representation of vascular endothelial disruption and inflammation. And that's why it's a risk factor for heart attack or stroke. Now, you add in something like I have migraines, then we have to say, well, what kind of migraines do you have? Do you have migraines with aura? Because that also is a risk for stroke, and we have to do a risk benefit analysis. But you're very much right to think about it and to consider how does this apply, and a good internist can help you with that and help you flesh out all of those risks very clearly. Dr. Lynn, what do you want to add?
Yeah, no, I completely agree with everything you've said. People who have vasomotor symptoms are at higher risk for things like heart attacks and cardiovascular disease. We know that just exactly like you said, there's this window of opportunity to start hormone therapy where it can have a cardiovascular benefit. There are two main benefits: estrogen, when started early, within 10 years of the last menstrual period, but the sooner the better, can decrease the chance that you would form atherosclerotic plaques in the blood vessels. It's also good for your vasculature. It makes your blood vessels less stiff. So there are some benefits to starting hormones early when it comes to cardiovascular disease. And that's true whether or not you have vasomotor symptoms. But vasomotor symptoms, we now know, are a risk factor for cardiovascular disease. The migraines with aura, migraines with aura are not a complete contraindication to hormone therapy. They're a contraindication to oral contraceptives or like the NuvaRing, because that can increase your risk for stroke. But people with migraines with an aura can still use hormone replacement therapy, which is a much lower dose than what you would find in a birth control pill.
Yeah, absolutely. I mean, and that's a great clarification. I have used and allowed people to be on hormones despite having migraine with aura. We typically try to do a transdermal patch instead of going straight to oral meds, which some insurances prefer. But that's my strategy. Is that what you do, or do you do something different?
Yeah, I think you can use either, but I do think transdermal is a better option.
Yeah, that's a great question. Uh, Dr. McKean, what blind spots are we having on this? What do you see?
these are some of these things that come up in my practice, but they're certainly not my expertise to comment on those increased risks. But I do have, certainly people that are like, I thought that I was already through this. And then like, why is this coming back again?
Mhm.
And it, for me, always just circles back to They need to have a good team of people. They need to have, if they feel like they aren't being heard and listened to by those that they are working with, then like, let's find them clinicians, because there are plenty of us around
Yeah,
um, that are there to provide that. So
good
Yeah.
point.
And hot flashes do come and go. That's so common that people will say, oh, I had them really bad and then they went away and I thought I was done. And then all of a sudden they come back with a vengeance and you're like, oh, I'm not done yet. So they definitely come and go.
And it seems like they get better year over year and decade over decade. But I certainly have 70-year-old women or 80-year-old women who be like, I just had another hot flash, right? And so it is real. A follow-up question to what we were discussing being if there's a contraindication with a monthly migraine medicine and estrogen therapy. I use both of these classes of medications in my patients. Some of the migraine medications, some of the older ones, I worry a little bit more about than I do the newer ones. But in general, I don't see a reason why somebody can't have treatment for both.
Yep.
Sometimes when they're on estrogen or when we put them back on estrogen therapy, what we find is the migraines go away, they get better. It was the deficiency that triggered them. Often this is the person who also would have migraines triggered either when they ovulated or right before their periods. That's what I've seen. What do you see in your practice, Dr. Lynn?
Yeah, I would agree. I see a lot of, we call menstrual migraines when estrogen levels drop. People will get headaches. So like right before their period or during their period. And so there are even, this is common even like in the reproductive years, in your 20s and 30s, we'll see this. And there are several birth control pills that those 7 days off of hormones, they give you some estrogen back. So things like Merced or Seasonique. And those work really well for people who get those menstrual migraines right before their period or during their period. So yeah, I see that a fair amount.
It's interesting too when you think about hot flashes, and I think actually this might be a little bit in your realm too, Dr. McKean. Night sweats are just hot flashes at night, right? And so where do we see them affecting sleep? Which lack of sleep for anyone causes them to be grumpy and have depression or anxiety and all the things, plus weight gain, which is just a horrible circle. But if you had someone in the perimenopausal or menopausal years, Dr. McKean, and they're working with their team and they're doing the estrogen, or maybe they can't and they're doing something different. How does that play in for you when you're thinking about it from a sleep and a mood perspective?
So I have folks that have hot flashes both perimenopausally, but also sometimes can be a side effect of antidepressants and medications I prescribe. It can also be something that's treated by the medications that I prescribe. And so sometimes it's figuring out what's causing the hot flashes. But certainly, when it's medications causing it, if right, it's that risk benefit sort of scenario, like is the medication helping, but there is this kind of annoying side effect with it, then I tend to prescribe glycopyrrolate with it. It's one of the few situations that I'm amenable to prescribing something to treat the side effect of something else. Most of the time, if I prescribe something and it's causing a side effect, I try not to do that. Now, this would be more the setting of like, yes, a perimenopausal symptom. And if maybe, for instance, I prescribed venlafaxine or Effexor that's supposed to be helpful with hot flashes, but it's not doing that, or in rare cases, it makes it worse, but maybe it is helping their depression, it is helping their anxiety, then we might leave it and then we might add like glycopyrrolate on. And there's other medications. Occasionally I have to refer on again to like primary care or derm if those things are not helping, but we want to keep the medications in place. But it's really, if
Yeah.
it's affecting sleep, I also recommend like wicking pajamas, wicking sheets, like anything that can pull in. If either this syndrome or the medications in general, if it's just the sweating that's the issue, then I'm like, we just kind of like go with what are the least intrusive methods of like treating that. And it's a lot. Like when I learned about wicking pajamas, I didn't realize how many people hadn't heard of them. And when they work for people, they really, really work. And for some people, like that's all they need. But sometimes it can get really complicated and really annoying if they're like, I've sweated through my pajamas like 3 times and nothing is helping. And then that's when I would probably talk about adding on some additional hormones and referring on to treat that if what they're doing isn't working.
I love that. For the person who may be listening to this and is like, what in the heck are wicking pajamas? What else would you tell them?
I would tell them that they are these delightful pajamas and sheets you can get that are going to pull the moisture from your body. So make it so you don't wake up with those. So it doesn't treat the hot flashes directly. It's not going to make you not have them, but it is going to make you like not wake up feeling like gross. And and sometimes again, if it's something as simple as that, that's like not adding a medication, then that may be worth it. And I've definitely had people, if it's like mild to moderate type symptoms like that, that those have worked. When things get severe, like they can help to some extent, but we usually have to be utilizing some other things. Is this something that either one of you guys recommend as well?
I
Yeah.
love this idea. It's not
Oh,
something I've used a lot of. Sorry, I didn't mean to interrupt you there. But I think that probably most people don't know about them, like you're saying.
yeah. No, I definitely recommend them, just because they wick moisture away. It's kind of like exercise clothes,
Mhm.
where they pull the moisture away from your body, because one of the main things about a night sweat is your clothes, your pajamas get soaked and then you get
Yeah,
freezing cold. Now
right.
you can have the chills after night sweats
Mm.
regardless. And then you have to like get up and change your clothes. So yeah, there are wicking sheets and wicking pajamas, and there's even like, I don't know, I haven't recommended this in a while. There's even something called the Chillo, which is a pillow that you freeze. There's lots of different ways to deal with hot flashes that are not hormones if you
Yeah.
can't use hormones or you don't want to use hormones. But then I was also going to mention that there is a non-hormonal medicine for hot flashes and night sweats, which I think we've talked about here before, called Veoza.
Mhm.
Like if you have a contraindication to hormones or you just don't want to use them for whatever reason, this is a non-hormonal treatment for hot flushes that works really well.
I haven't had anyone go down that road yet. And so I don't have probably as much anecdotal response that I can offer on it. What have you seen compared to the people who use hormones who are using it?
Yeah. So I think Veoza works really, really well for hot flashes, and it works pretty rapidly. Even in their clinical trials, people noticed a decrease in severity and frequency of hot flashes by week 1. And that was the first time they actually asked people. But I feel like it works pretty quickly.
I love
The
that.
thing, yeah, and I think it works really well. The thing with Veoza, all medicines have risks and side effects, is that you have to check liver function tests. When the medicine first came out, they recommended that you check your liver baseline, like LFTs and bilirubin, before you start it. And then I think it was at 3 months, 6 months, and 9 months. But after it's been FDA approved, they've changed that now. So now you have to check it month 1, 2, and 3, and then 6 and 9 months, because they did have reports of liver toxicity in their clinical trials.
Yeah, and that's something you don't want to mess around with. I've seen that from some other drugs. In internal medicine, we are looking at liver and kidney quite frequently, actually. And this is a great example of drug-induced liver injury is deadly, is not something to screw around with. So I'm kind of curious because all of us, with this focus on menopause, we see and hear the woman who may have struggled with weight gain all her life, and how do I not gain more because of menopause or because of medication she's on for mental health or different reason is gaining weight, and then menopause exacerbates it. But one of the probably the biggest things I see in my practice that gets ignored is the liver, because what the lab considers to be a normal liver value is different than what a liver specialist would consider to be a normal liver value. And
Oh,
so when you get those labs and your ALT, which is our kind of main marker for liver cell dysfunction, and it's 30, the lab's not going to flag that as abnormal, but for a woman, it actually is already elevated. And so I see a lot of fatty liver and I see insulin resistance, and I would worry in somebody like that about a higher risk of having dysfunction, and just calling that out to them and saying, hey, your ALT is already 30. We're going to pay really close attention and make sure it doesn't go up, because a lot of times the labs won't flag it until it's over 50. A normal for a woman is less than 20. So if we're waiting until it's 50 before we flag something, we could easily be causing harm and not getting ahead of it for her.
interesting. Yeah, I
Fun
see a
fact of
lot
the
of,
day.
that is a good
Yeah, I
fact.
wasn't aware of that.
Oh,
Yeah, I wasn't aware of that. Yeah.
Never heard that. But I see low levels of LFT elevations a lot. And
Correct.
feel like, a lot of times it's fatty liver due to obesity. And I
Yes.
think many people don't realize that when you have obesity, the liver is affected and it fills
Yes.
up with fat and can really affect its
Yes.
function. So yeah, good to know. And another reason that it's good to lose weight if you're struggling with obesity and get yourself
Right.
to a normal weight.
Right. Absolutely. And I think it's a little bit scary if we're relying on just lab values, right? Because we're not thinking there's a problem and yet we're potentially harming. But even if you're not using these meds, like everyone should have their liver labs checked at least once a year
Yeah.
and know the term for fatty liver continues to evolve. It's now called metabolic associated fatty liver disease, just to distinguish it from alcoholic liver disease. And the numbers are striking that it used to be, 30 years ago, if you need a liver transplant, it was because you'd been an alcoholic. And now obesity is driving the need for liver transplant more than that, which
That's
is
crazy.
shocking, really
Shocking.
shocking. One of the things I see is that people don't realize the connection between fat accumulation in the liver and insulin resistance. I have a lot of people who've done a great job. They've lost weight either with lifestyle measures or with medication, but they actually haven't fixed their insulin resistance. And that insulin resistance is what's causing a downstream effect for them that's going to lead to long-term problems. Um, we're seeing more and more people wanting to take these medications short term because they're paying out of pocket if their insurance isn't covering it. But what I'm noticing, and there's now studies showing this, that if you don't stay on those medicines, unless you've made dramatic changes and reversed your insulin resistance, you're going to gain the weight back. And what we know about the liver is that it does not tolerate stress of gaining weight, gaining weight, losing weight really well. At some point, there is going to be some scar tissue that develops. So, just a thing to be aware of, especially in our women who, this time of life, just lets that fat want to stick. You can't
Yeah.
even look at healthy food and your hips not feel like they're getting wider, I feel like.
Yeah.
So,
Yeah.
it's
I mean,
not just,
yeah.
go ahead. Yeah,
I think it's one of those things our bodies are programmed to put weight back on.
exactly.
So even if you did keto and you stop doing keto, that weight comes right back
Yeah,
on. And I may have mentioned this
exactly.
last time, but I heard this really good podcast. Somebody said like the house always wins, right? Like if you go to a casino, the house
Mhm.
always wins. And so your
Right.
body is going to do everything it can to just put all that weight back on.
And
Um,
it's supposed to,
yeah,
right? Like nothing has actually gone wrong in what our body's doing. It's just an exaggerated response to the biology that our ancestors had 1,000 years ago. But
yes,
it's not actually a problem. It's the ramification of our genetics.
yeah, yeah. That's an interesting way to look at it. I like that.
Yeah, I find it liberates people, right? They feel like they've done something wrong or bad, or their body's somehow failing, and your body's actually doing exactly what it's supposed to do.
Yeah,
It's just
true.
overcompensated in now
Yeah,
a way that's harming us. And
yeah.
there is a question in the chat to confirm that ALT is that liver measurement. Yes. I didn't know we were talking liver today, but apparently we are.
We never know. These conversations always take little twists and turns.
Yeah.
Yeah, that's
Um,
the fun part.
I was going to say, and I think I said this last time, but this so sticks with me, how humans maintain like a normal percentage body fat for humans is much higher than every other single mammal. Did I mention this last time?
I
I'm
think you
just
A little
mentioned
bit.
it from that. I think it was coming from wasn't it something that you
the
heard at the
podcast.
conference?
Like,
Yeah. Or it was a podcast. Okay.
oh no, it was a scientist. He was like an evolutionary scientist on Sanjay Gupta's podcast, and they were talking about how most mammals will have a 4 to 5% body fat, whereas for us, like 30%, 25%, like we're so much higher than regular mammals, and it's a good thing because we need all that stored energy to protect our brain because we have big brains. So it's so like it's I know I'm saying it twice, but like I just find that fact so fascinating. But I mean, that's like you said, evolutionarily, that's our bodies are doing what they're meant to do, but it really causes problems, with obesity and all the downstream effects of it.
And here's another interesting thought. You've got 30, 40, 50%, whatever fat accumulated in someone who's carrying extra weight. If you have insulin resistance, you can't tap into that energy. You're burning carbs, you're not burning fat, and that's a problem.
That
That
is,
I don't think people realize, even when they're dieting, that if they've got insulin resistance, it doesn't matter if you're on Mounjaro or these fancy drugs. If you have insulin resistance, your body can't use the energy it's stored. So you're not going to lose weight effectively. Your big brain is going to be feeling like there's a problem because it
Mhm.
can't access it.
and so that's one of the reasons why sometimes I get frustrated when people come and they're like, oh, I have pre-diabetes, but nobody did anything about it.
Right.
And I'm like,
Right.
that's why you're gaining weight, because you have insulin resistance and it's working against you. But
Correct.
typically, and I just feel like in general, people are like, oh, it's pre-diabetes, we don't have to get to diabetes, just eat healthy. And then, I feel like a lot of times for people, they just didn't get that message that it's contributing to your weight gain. They
Absolutely.
might need some
Yeah.
guided tools to help them with weight loss. What they're eating for sure is definitely different from someone who doesn't have insulin resistance and exercise and all of that.
Well, and the other interesting message they don't get, and thinking back to medical school and residency, I don't think I really understood it even then,
Yeah,
is that
I didn't.
if you need to lose weight, if you have insulin resistance and you're trying to eat a healthy diet, what's healthy for the general population is not healthy for you. And
Mhm.
this idea of a balanced diet, which you'll read all over the internet, even on really good places like Cleveland Clinic, right? They're like, eat a balanced diet. But
Mhm.
if you have insulin resistance, you have no business eating any grains or any dairy until you get that reversed, because that's going to stop you from reversing your insulin resistance. They cause insulin resistance. And if you're not metabolically well, it's just going to take your efforts longer and you're not going to be as successful. Uh, but most people don't understand that. They don't make that connection. It doesn't mean forever, but until you reverse it, you need to not have those as part of your diet. Vegetables and lean proteins, uh, unsaturated fats. And that's just not something most people even know what those are. If I asked my non medical friends or family, what are the 3 unsaturated fats? Give me an example right now. Go. They look
Yeah.
at me like I'm just like, put them in front of what's the deer in the headlights look, right? And so fats are so important for the brain, and having your nuts or your seeds and your olive oil and your avocados, those are all things that everybody should be eating every single day.
So I have one question for you when it comes to like reversing insulin resistance. You see people who are diabetics who are thin, right? Type 2 diabetics who are thin. So,
Yep.
so, I've always looked at insulin as like partially it's genetic, because you also see people with severe obesity who don't have insulin resistance or diabetes or pre-diabetes. So what do you say to that person? I'm genuinely curious.
Yeah. 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 So the first person, I have some of these patients whose BMI is not obese, maybe they're not even in the overweight category, their body's not using insulin well. And so what we do, and I think you both do it in your practices too, but we really tailor each treatment plan to each person. And so and I'll give you an example. I see this in the Asian population quite a bit.
Mhm.
And you may recall that Asian people's BMI is not measured at the same way that every other ethnicity is. And so they'll have a quote normal BMI, but they're actually overweight or obese for their ethnicity. And what we see is evidence of insulin dysfunction. Even if their insulin level is normal, they'll have skin tags, or they'll have the darkening of acanthosis under their armpits and their groin, at the back of their neck. They'll get sleepy after eating carbohydrates. Those are all signs of insulin resistance, even if you don't have an elevated insulin or your BMI is not elevated. So I'm always looking for those other signs and really stopping to say, what evidence do we have of what your body's needs are and what they're doing? I now test every patient their basal metabolic rate as part of their wellness visit, so that we can understand what their body's needs are, and recognizing that year over year this changes. And this is not something that any of us learned, I think, in medical school, and it's not something that the general public even knows is available. And so for the person who's a normal weight, I look at their ethnicity first. But
Mhm.
second, then I'm looking to see, well, what is your metabolic rate and how is that playing into the bigger story? And are there signs on your body that you have insulin resistance that maybe the lab tests haven't caught yet? And then the second person you said is the person who's overweight, but their insulin's normal or they don't have evidence of insulin resistance. There was a really nice study that was done, and it looked at people who were overweight and so-called metabolically healthy versus people who were normal weight and metabolically healthy. And even in that category, the people who were overweight or obese had mortality differences. So there
Yeah.
is no such thing as being, I think the term's fat and
Oh,
fit or something like that now,
yeah. Yeah.
that you'll see trending. That's actually not true. Their insulin levels are normal for their body, but they weren't necessarily normal compared to the outcomes. They had higher inflammation and they had mortality differences. So it's not what it seems. And if we don't
Yeah.
have teams around these patients helping them, they're going to have outcomes that we could have at least modified, if not prevented.
Mhm.
Does that help answer your question?
100%. That's awesome. Yes.
I feel like my voice is about to go, so I'm going to pause and talking and let you two go
Take
over.
some hot tea or
Yeah, just not voice rest, the thing that we are supposed to do and don't.
I have a little something to add. Just I'm a big podcast listener, and obviously I listen to people I respect who are, experts in the field, because you can find some craziness in just any random podcast. But one of my friends and colleagues is Dr. Kelly Casperson. I don't know if you guys know her. Uh,
I
she's a urologist, and she does a lot of sexual health and menopause and all of that. And so I listened to her podcast this morning where she interviewed a dermatologist who does a lot of hair things in menopausal women and perimenopausal women. And I thought it was a really good podcast just to hear it from him. And a couple of take-home messages that I learned from that is, one is that 50% of menopausal women will struggle with hair loss. I'm like, that's a lot. That's a lot.
That's horrible.
Yeah. But then the other thing about hair that I have learned in the past, which I always find really interesting, is that the diameter of the hair shaft gets smaller in menopause. And one thing that the physician talked about this morning, how there's really not any studies that look at, if you give somebody estrogen, what happens to the hair. Like, nobody's looked at the diameter after you do hormone replacement. And we have to keep in mind that hormone replacement is a much lower dose than what your own ovaries were making when you had your reproductive years. And then the other things that he pointed out, which I really just hadn't thought about, is things like tight ponytails. Like, tight ponytails or really tight braids can be really harmful to your hair. And then of course he also brought up like hair drying and straightening, and yeah, we know that's bad for your hair. But it was a very good podcast if anybody's interested in hair loss in the menopause.
Say the name of it again, or who it was with.
So Kelly Casperson, she does a
Yeah.
podcast called You Are Not Broken.
Mhm.
Love that.
Yep, she's awesome. She's great.
It's
Yeah.
such
One of the things that the questions I always get in my practice is, oh, is there a supplement I should take for that? Is there something I can do to make my hair stronger? Because it will come up occasionally with certain antidepressants or other psychiatric meds, a lot of times we'll think it's because of them that's causing like the thinning hair. And then, we go back the trajectory of when they started it versus when, there's a timeline of especially like acute stressors. And if you've had that, it's 3 to 6 months later that you actually see like significant changes to your hair from those. But I still always get asked all the time, like supplements to improve that. So beyond something like biotin, which kind of everybody hears about, was there anything in particular that Dr. Casperson was recommending?
No, so they purposely avoided, this is just my opinion, they purposely avoided talking about things like Nutrafol and a lot of the supplements that are out there. They wouldn't say, they said like a little bit about supplements, but didn't want to mention anything by name. I have also listened to Lauren Stryker, who's also a colleague and a friend. She has a podcast too. And I love it when like my doctor friends in my same world have podcasts, because I always learn from them. And she did one on hair, and she talked about one study in postmenopausal women who took Nutrafol that found that per square centimeter, they had 7 more hairs per square centimeter than placebo. But as you can imagine, the data on Nutrafol is sparse, right? Because it's a supplement, so it's not regulated the same way. They did talk today about minoxidil, spironolactone, and things like finasteride and dutasteride. I prescribe minoxidil. Well, first I do a panel of labs because there are certain things that can lead to hair loss, like low vitamin D, low ferritin. So I have a whole panel that I check. And if all that is normal, then I'll often do minoxidil because it's cheap. And you just do a really low dose and it does thicken your hair. It has some issues though. If you stop it, your hair will go back to what it was before. And it causes hair growth everywhere. So, it's not specific to your hair. And I use oral minoxidil. They talked about using spironolactone in addition. I don't routinely do that, but this dermatologist who was on there, he routinely does, because it blocks the conversion of testosterone to dihydrotestosterone. And then he also talked about dutasteride and finasteride, which I never use because I'm not comfortable and they're not good if someone's going to get pregnant. And they can have sexual side effects. They can lower your libido. So I don't routinely prescribe them, but sometimes I see patients who have seen dermatology and they're on, minoxidil and finasteride or spironolactone or something like that. They talked a little bit about PRP, which I thought was interesting too, that he was a believer in PRP, which is platelet-rich plasma, that it kind of helped the hair follicle. Gosh, I wish I could remember how he described it exactly, but it was part of the whole picture and it really worked, a little bit more closely on the hair follicle. So I guess the take home message is women in postmenopause definitely can have hair changes but there are things you can do. And then the last thing that they pointed out, which I also think is really important, is not all postmenopausal hair loss is due to low hormones. There are definitely other things that can happen. And so like some of the things he talked about was like if your hairline is backing up, there's something called something like alopecia with fibrosis or something like that. Or if you have patchy bald spots, that's not classic for postmenopause. So if you're having anything that's not just a generalized thinning, you probably definitely want to get that checked out.
Yeah, and going back to the meds you were mentioning, we do use finasteride. Of course, you have to watch for the sexual side effects, like you were saying, watch for hypotension and or low blood pressure. I do use spironolactone as well. One of the things remember with spironolactone is that it's not safe in pregnancy, to your point. So in those perimenopausal years, you can still get pregnant. The other aspect of it is it can cause your potassium level to be high. And so we just have to monitor your labs, which is not a big deal at all. But if you're not checking those, then you can run into problems with other supplements or meds or just lifestyle and dehydration and whatnot. But those are good options. I have not had anyone do PRP. That's kind of an interesting thought for that.
Yeah, I have one patient who had PRP and thinks it worked.
For their
Yeah.
scalp,
On their scalp.
interesting.
Um,
Yeah. I've
yeah,
just
so
had patients do it for joints.
I used to sublease space from Dr. Samuels, who's a
Mhm.
dermatologist who specializes in hair. And he did a lot of PRP and he did hair transplants too. So I was
Interesting.
kind of working in a little hair center for a while. I don't work there anymore.
That's so interesting. Maybe my husband needs to go there.
Yeah, yeah.
Right? Our menopause talk, and I'm thinking about guys, but it is a real concern. I also see, and you may want to touch on this too, in the perimenopausal years and after menopause, I see some women develop the same presentation as PCOS from their reproductive years, meaning there's a hyperandrogenetic state and they're having those high androgens relative to what their baselines were, even if they're not taking hormones. Do you see that and run into it much in your practice? I get concerned because of the cholesterol and the glucose and the weight gain and whatnot, but do you see much of that in your world?
No, but what I do see, when it comes to hormones is like I see adult acne, right? So hormonal acne, I see that a lot in perimenopause where people didn't really have skin problems and all of a sudden they've got the whole long list of perimenopausal symptoms and now they have zits. And it's so frustrating. And so we use spironolactone for that all the time to block testosterone. And the other thing that contributes to that is in perimenopause, your estrogen levels can get really, really high, like super high, and that can contribute to acne also. So I wouldn't say that I routinely see like new onset PCOS, but people with PCOS are more prone to acne and facial hair, and I definitely see that in your 40s.
So interesting.
Yeah.
What are we missing? What are our blind spots that we haven't talked about today?
I was curious if either of the people listening in had any other questions for us, for sure. We've talked about lots of things, as this is what, our maybe 5th time doing this, I think. So
Yeah.
certainly would entertain any other questions. Back to basic sorts of things. We probably talked about this like the first time, but it still comes up a lot and I still don't always know the right answer for it. Is, I have folks that are taking birth control like long term. Maybe they like finish their, like, having the amount of kids that they wanted to have, and for whatever reason, maybe their spouse didn't get a vasectomy or something, so they're on it sustained, and they're wondering, like, at what point is my OB-GYN gonna, like, not refill this? At what point, or at what point, if it might be masking me knowing if I'm going through menopause, like, when would they pull me off of it? Or when should I come off of it to see where I'm at in things? And I was
Yeah.
just curious what guidance either of you would give an individual that had that question. Like, maybe she's like 46, 47. She's like, I've been taking it for 10 years. Kind of don't want to take it anymore, but I don't know if I should or I shouldn't. And what sort of
Yeah.
guidance do we give people?
So it will mask menopause. You could keep somebody on OCPs till they were 70, they'd still have periods. So it will definitely mask menopause. But so what I do in general is around the age of 51, which is the average age of menopause, we stop it. And then we give it 3 to 4 weeks and check an FSH. And if it's elevated, like really elevated, I'll
Yeah.
repeat it again in a month because FSH can fool you. Like, for example, I had a patient the other day who had an FSH of 40, and if you look at the lab cutoff, 40 says menopause, but her estrogen was 500 because she's perimenopausal.
Mm-hmm.
So I've definitely, and I've also seen people who came back with like an FSH of 60, and then they had bleeding and breast tenderness and bleeding like a normal period, and we check an FSH and it's now 20. So I feel like you have to at least have 2 good FSHs a month apart to say, okay, now you don't need birth control. But in general, I will say, let's just do that at 51. But it depends on the person. If they're like, I really don't want to be on the pill anymore, but I don't know if I need contraception, you can stop it temporarily, see if they're through the menopause. And if they're not and they want to go back on it, they can definitely go back on it. So there's no hard and fast rule when you have to do it. But I tend to do it around 51, but you can technically keep people on birth control up to about 55, the right candidate, right? A low risk.
Yeah. I think that's what some are worried about, is they're in their, maybe they had their last child like late 30s, early 40s, and they're like, I don't think my OB-GYN's going to put me on birth control. Like, my mom didn't go through menopause till her mid 50s. Like, what am I going to do for all this time? And so encouraging them to still have those conversations and advocate for themselves. Or again, as we keep saying, like, if you feel like someone's not listening to you, then like find somebody that will, because if you've got 15 years left before you're going to go through menopause, then and you're sexually active, then you're probably going to need some form of contraception.
And there are other forms of contraception that don't have the same risks as oral contraceptives with estrogen, with ethinyl estradiol in them. So like I use a lot of Slind in my practice. It's progestin only. It's actually spironolactone or drospirenone, sorry, a brother of spironolactone, drospirenone. And it doesn't have the blood clotting risk that ethinyl estradiol does. So I use that pretty often, or you can do a progestin containing IUD if you're trying to avoid the ethinyl estradiol in a regular estrogen containing birth control pill, because they still need birth control because people get pregnant in their 40s. So yeah.
For a lot of them, I try to get them to have another conversation with their spouse if that's appropriate for vasectomy, because I'm like, that will certainly help you
Yeah.
also.
And vasectomy, like when you look at vasectomy versus a tubal ligation, vasectomy is so much lower risk.
Mhm.
So I realize there are men who would never do that, but you know, it is not as risky as a tubal ligation because the tubes are, if you do a laparoscopy, you're in there in the belly
Or
by
general anesthesia, like it's just.
bowel, general
Mhm.
anesthesia. I would highly recommend if you want permanent birth control to go the vasectomy route if your partner will do that.
I've heard some women talk about how like they have done all the medical investment in their relationship, if you will, the birth
Yeah,
control, the doctor's appointments, whatever, and it's their turn, their spouse's turn. Um,
yeah, 100%.
See another
I
question about vaginal dryness, best approach for painful sex.
Mhm. So vaginal dryness, totally common in menopause. The vaginal tissue changes. I know I repeat myself, but we have new listeners this
You're
time.
good.
But premenopausally, the vaginal tissue is thick, it's moist, it's got a lot of cells that make lubrication, it has collagen and elastin, so it stretches, so it works for sex. A fetus can fit in it and a baby can fit out of it. But when you go through menopause and you lose that estrogen, the tissue gets thin and dry. It doesn't stretch, doesn't make a lot of lubrication, and so sex becomes painful. Vaginal estrogen is the best choice for all of that. It will restore its flexibility, its ability to lubricate. It won't make as much lubrication as you did when you were 20. You'll probably still need to use a lubricant, but so much better with vaginal estrogen. And the main thing to remember about vaginal estrogen is it does not have an increased risk of blood clot, heart attack, stroke, breast cancer, nothing. Even though the package insert says that it does, you can ignore that package insert. It's a lie. And then you might say, why? Why is that package insert on there if it's not true? And it's in there because the FDA mandates that any estrogen containing product have the same label. So whether it's a pill or a patch or anything, it has to have the same label. But we know that vaginal estrogen does not have those risks. And it does a world of good for the vagina. It lowers your risk of getting recurrent bladder infections. So that is my big push for vaginal estrogen. If someone still has, yeah, vaginal estradiol, pretty much. There's also a DHEA that you can use in the vagina. If someone doesn't get better with that, the second thing you need to look for is pelvic floor muscle spasm or hypertonicity of the pelvic floor, which can also cause painful sex. And this can occur up to 30% of the time. So when someone comes back and they're like, I'm still having painful sex, and you gave them estradiol, I always check for pelvic floor muscle spasm. Or sometimes people do better with something that has testosterone in it because the vagina has testosterone receptors. So there is a product called Intrarosa that gets converted to estrogen and testosterone in the vagina. So if somebody didn't do well with estradiol alone, that's my next go-to. If their insurance doesn't cover it, you can have a compounded estrogen testosterone, which might be cheaper. But the vagina definitely has testosterone receptors, and that's why people on birth control pills, which lower your testosterone levels, can have vaginal dryness, even though they're getting estrogen in those birth control pills.
So interesting how the system is complex, right? We tend to think of it as not being that big of a deal, and yet there's so much that happens in the vagina.
Yep.
It's super interesting.
Yeah.
I love that. And it looks like I think we got all the questions in the chat answered. So if there's any others, go ahead and drop those in as well. One last question that I wanted to just think through with you both is I had she's probably 70, African American woman who came in and had been on hormone therapy historically. She'd been off of it maybe a year or so because she'd ended up having some heart palpitations. That took her to the emergency room. She was admitted because of her age. She doesn't actually have any structural heart problems. She has high blood pressure. Get her high blood pressure fixed and it goes back normal. But when she came to me anyway, no one would put her back on hormone therapy because of her age. And so she and I did some risk benefit analysis and whatnot. But I'm curious, do you see that happen in your practice too, where somebody's been on it for years and for whatever reason they're taken off, but now consider the risk is just too high magically? How do you work through that in your mind?
Yeah. So there's a difference between starting someone who hasn't been on hormones for 20 years, starting them at age 70, versus someone who's been on hormones since they were 50. There's a huge difference in that. And I see this happen a lot, where someone will have been on hormones for a while and then maybe their doctor retires, they get a new doctor, and that new doctor says, I'm not refilling these. And so they get off them, and then they're so frustrated because they don't feel good. They have hot flashes that they haven't had for 20 years. And they want to go back on. And so, of course, you have to look at the big picture, the risk benefit analysis. But if they're otherwise healthy and have been doing well for a long time on hormones, and like you said, her heart ended up being fine, I would probably put her back on hormones. So then the question is, how long is too long? And we don't have that answer, right? Like, is it a year and a half versus 5 years? We don't have that answer. Maybe we will one day, but we just don't know.
Yeah, and that's the conversation we had as well. And one of the things I talked to her about is 10 years ago, we would have said, even if you've done well on hormones, by 70, you should really come off of them. And there is now data that suggests there are 70-year-olds that should be on estrogen still, and that it does have to be tailored to each patient and personalized. And so it could have gone the other way too. She could have had a heart problem that really was contraindicative of being on it. If she had had forward atherosclerosis, for example, and lots of blockages, I would be a lot more uneasy about starting that than if she had nothing and calcifications in her arteries. So I was just curious if you run into that much and what you do, but it sounds like we typically do along the same line of thought and how we're approaching them.
Yeah.
I think it definitely just heralds
I think we
the
lost
idea
you.
of like that people need this Women's Health Initiative study that kind of swung everybody being like, no, everything's bad. And it's taken so long. There were always some that were like, well, we could still kind of do this risk assessment, but that wasn't the general theme. And I think we're still fighting the fight on like getting more and more people to see that in general, the vast majority of women actually can take hormones safely, and that it's going to improve their quality of life. But I think that the patient you're talking about is just super lucky that you weren't just like, oh yeah, definitely no, you can't. You're 70. You shouldn't take that at all, and not be willing to kind of like, again, do a full risk assessment.
Absolutely. And that's what I love about all of our practices. We have chosen to step away from the big model of care, right? And we don't have 3,000 patients anymore. That was awful. And being able to spend more time with our patients and really understand their needs and figure out what's going for them. I think that's one of the beautiful things that we've each experienced. So if you haven't already, I'm going to invite you to put your information in the chat so that our listeners can see that, your clinic and whatnot. Are there any last things that everyone should know? Any last dying thoughts before we let them escape?
I don't think so. I just put in the chat too, for those that are attending this one or that watch the replay later, that we will be back to our regular schedule of the first Wednesday of the month at 1 p.m. starting next month. And I believe we will be joined by an amazing local dermatologist named Dr. Sarah Jensen. And we're hopeful throughout the year to invite some other guests in different subspecialties to help stir the conversation, and provide as much information about perimenopause and postmenopausal symptoms as we can.
Love that. What about you, Dr. Lynn?
No, I don't think I have anything else to add. I'm just grateful that I get to do this with you guys because I always learn something from you, and I love that. So yeah, we'll post this on Evora's YouTube channel, Evora Women's Health. And then I don't know where you guys post it, but I'm sure it's posted somewhere. So if you have friends who want to watch the video or anybody who is interested, they can find it online on YouTube.
Yes, love that. Vitality also has the YouTube channel. We try to do video teaching topics. So I put my Instagram and TikTok if you want to follow it. I think, Dr. Lynn, you have both as well, right? And are you just on Instagram, Dr. McKean, or do you have
Right now, I'm
others?
just on Instagram because I'm just
Keep it simple. Keep it simple, man.
I'm a solo lady. So,
Oh,
my 1 year anniversary is coming up in a couple weeks. So
oh,
even the LinkedIn has
congratulations.
told everybody that it was, I guess, yesterday or something. Officially it's like
Nice.
January 22nd. So, I'll be probably trying to like in year 2 branch out a little bit more, but I was just trying to kind of get my feet wet this
You did
past year.
it. Good job.
Yeah, congratulations.
Huge congratulations. Well, grateful to be here and see you. Thanks to our listeners, and reach out. Let's talk and have this menopause conversation and journey continued and continue to make it better for women everywhere.
All right. Take care, guys. Happy New Year.
Bye. You too. Bye-bye.